So, friend, here we are. We're kind of looking back a little bit at 2021 and looking forward to 2022 at a very unique period of time. And it's probably safe to say that there's been no greater influence on the healthcare sector writ large, from financing to delivery to regulatory, whatever, than the pandemic. So let me ask you, what has been the impact on the healthcare ecosystem of this pandemic, and how would you illustrate the significance of reading the tea leaves, so to speak, maybe by sector?
Yeah, you're dead on target. And essentially, when you think about it, the pandemic hit the ecosystem all over the place. So one thing that people forget is that huge government funds came in to cover a lot of stuff. Funds to hospitals, funds for testing, funds for all kinds of services that essentially took those costs off of what would have been the normal payment system, like the health plans, et cetera, and allowed hospitals and others to make up for the supposed issues they faced. One, treating patients with COVID, and two, losing the ability to treat others and losing that influx of patients. What's been interesting, and this is anecdotal, of course, is I've heard a couple of health systems that have honestly said, thanks to the influx of money from the federal government, we had a fantastic year last year and made a lot of money. And interestingly, a few of them have used that money for perhaps some other things. But it's clear that you've had that impact from a financial perspective. You've then had the impact of just how hard this hit the delivery system. And by that I mean the individuals that are taking care of these patients who are essentially pretty burnt out now. And so the question is going to become, over a longer period of time, do we see individuals stepping out of careers in the healthcare sector? We're hearing about some of that from individuals in nursing and areas like that. Although at the same time, we are hearing applications may be up for certain specialties in medical school and things like that. So you have that piece going on. And then you have this ongoing treatment issue and population health management issue, which we really haven't done a great job at. You know, the recent announcement that you brought up before we discussed this from the CDC, talking about the new 5-day issue of having somebody isolate if they've been, or quarantine if they've been vaccinated and asymptomatic but testing positive. Obviously, that message, if you leave a few words out, sounds like everybody can do a 5-day thing. So we have these swirling issues on a very large scale basis that ultimately are coming down to impact how well we deliver care or move forward. We've certainly seen where healthcare doesn't work. The pandemic has exposed that pretty strongly. And now the question is, do we go forward with anything that's different? Are there models we're going to put in place that are going to, one, change the payment models, and two, change how we ultimately deliver care to individuals, whether in new settings or new technologies?
Here we have, I mean, if you were to look at it this way from a macro perspective, the primary constituents in the healthcare ecosystem are providers, then payers, then there's some hybrid models, whether they're integrated delivery systems or, as you've often noted, payors. And somewhere in that spectrum are the advanced practice models, from ACOs to bundled payments to rolling out the direct contracting program, on and on. So, and honestly, most of the progress that I've read about is primarily in the government market because of federal policy changes. But how would you drop down and maybe characterize the impact of the pandemic in providers, payers, hybrids, and some of these innovation models?
Yeah, so the more advanced innovation models, in particular those that maybe were accepting capitation, obviously did not have this impact of suddenly their fee-for-service business dried up. Clearly, larger healthcare systems saw that. Whether that's enough of an impetus for them to then move to these newer advanced payment models is still debatable. I've heard from some that it's not quite enough. I've seen some surveys that say that. But at the end of the day, I think those that did some of these advanced payment models or alternatives were probably in better shape than those in a fee-for-service system. Clearly, there's a push now to at least continue to try to move that way. Obviously, Medicare is looking at various new ways to do it and tightening up various programs that they do. I think Medicare is an interesting space. There's been a plethora of companies coming into that space, and many of them go public, and the question then becomes, are they actually able to better manage the care? And there's some question as to whether or not it's a coding issue that's allowing for the increased reimbursement, or if they're actually able to then leverage what they call their population health management programs and do a better job. The payers are in an interesting situation because a lot of the costs for COVID were covered by the government. And some of their questions are going to be, when does that fall in our lap? And we suddenly have to start paying for some of this, like testing and things like that, as well as other treatments and things. And then the question further becomes from a health plan perspective, and we've talked about this at some of the conferences I've been at, is the issue of long COVID. If it's really very large, is that something that then could potentially be in a separate program or co-funded, similar to something like an ESRD program or something like that, where the government picks it up? Because right now it's a big unknown, and while many of the payers have said we don't see major impacts in our rates, I've talked to some brokers who are saying they're seeing double-digit increases in premiums for their clients.
So in one respect, because of the massive federal infusion of funding into the provider space, primarily just to give them a bridge to stay alive, to stay afloat, yet in some respects, it's kind of a bridge to say, hey, this is the transformation we've been talking about for decades. Maybe it's really here now, because after all, these integrated delivery systems that are assuming capitation and or all-inclusive population-based payments, they did much better under at least the trauma of the still unraveling pandemic than their fee-for-service counterparts. Are there lessons being learned there? And why isn't this the golden age for population health management?
That's a great question. It's still a lip service deal because the payment models are behind what should be implemented. So if it's a fee-for-service model, which is a big chunk of it now, everybody's still asking for another CPT code. Give me a CPT code to arrange housing. Give me a CPT code for food services. Give me a CPT code for telehealth. And while we keep adding those, that just keeps it safe for everybody to not have to move. And the reason I think this is so important and makes a lot of sense is if you move to a capitated model and you're let's say you're a healthcare system and you're managing this population in your community that comes to your system, and you suddenly want to offer housing. If you're capitated, you make the best decision for that patient based on whatever service it is, not on whether or not you have a code for it. So you could say, well, I'm going to run them through a food pharmacy, and that's going to save me over here. And that's why I'm going to do it, instead of, I need to add more reimbursement so I can do more stuff. And we're still stuck in that mindset.
And I keep coming back to what is the opportunity with the pandemic and some of these little niche sort of plays, whether it be virtual care, telehealth, telemedicine, are these likely to sort of retain the newfound gains? I mean, I joked on Twitter a day or so ago that, COVID did more for the telehealth, telemedicine industry than 20 years of advocacy by the American Telemedicine Association. So the question is, are these sustainable, durable gains, or will they simply be seen as a bridge, a temporary bridge to get legacy healthcare through this pandemic?
Well, we saw the huge spike, obviously, in telehealth. It was enormous. And then it came back to earth. And now it's higher than it was prior to the pandemic, but nowhere near what it was before. And the issue becomes, again, everybody looks at telehealth. Give me a CPT code. It's an add-on to my service. And I shouldn't say everybody, because I'm hearing some innovative groups talk about it differently, where you completely restructure the practice and telehealth becomes a component of it, whether it's your front door or it's a major piece of your service. But in order to do that, remember, hospitals have had difficulty moving to many of these models because it will reduce their inpatient load, and they've already built the facilities. Well, primary care has the same issue. if you could do 50 or 60% of primary care via telehealth, and you still own a building with 5 offices, bunch of staff, a parking lot, all of that, you still have to support that overhead. And so there needs to be some way to begin to transition that. And we haven't gotten there yet. I think, telehealth clearly was the golden child of one of the new technologies.
But these guys, I always saw the limited upside there, that they're sort of centralized models, that they're not nested in a health or sponsored by a health system per se, where there's sort of the back end, and the front facing thing is really the health system or the health plan or the local whatever in the region. I always thought they wouldn't scale because they weren't nested in the fabric of healthcare delivery per se. Has that changed at all?
No, I think you've got these competing models. One of them is we're going to put the telehealth system into our practice, and our clinicians, whether they're 100% telehealth or not, are the ones doing the work. I know University of Mississippi Medical Center, one of the National Centers of Excellence for Telehealth from HHS, one of 2, has their own physicians. And obviously, they cover the state and across multiple specialties. They're doing all kinds of different stuff. And then you have these that are independents that you bolt on to your healthcare system or your payer system that essentially take the calls in and have physicians around the country doing that. So it'll be interesting to see how those 2 models go, as you pointed out.
You were mentioning before we went on air that apparently at least one or several of these valuations from the stock market point of view have been radically hit.
In particular, I had seen Amwell's right after they went public. There was some rumor that they were being acquired, or maybe it was an Optum or something. I don't even remember. And they shot up, and now they are really down considerably from their open and everything. So it'll be interesting to see where those go. I know there have been some writings on Teladoc as well, whether they may be the one to just, really be the strong player in the space. But only time's going to tell. I think there's still this question of how do we successfully integrate this stuff to actually show results and reduce some costs. And at the end of the day, it always seems to be the double aim. We're working on improving the health of populations. We're looking at the other one, but we're not focusing on costs. We're just not. It just seems like they go up and then they go up some more.
So I don't claim any deep insights here per se, but I'm wondering if there's any merit to this idea that there's a future for these telehealth companies in the Intel Inside model, where really the brand, the forward-facing product is the local health system or the health plan, as I mentioned. So you think there's any upside there?
Yeah, potentially. I think a number of providers go that way. I don't know, who some of the hospitals that I know of use as their telehealth system, but they're running it. They're the doctors staffing it. Same with Mississippi. I don't know what they're riding on in terms of the platform, but they are doing it. And obviously, I think from a patient perspective, it's always nice to sort of know your provider. And I guess you can get that through these outside ones. But if you're a patient with some serious illnesses and, being managed beyond perhaps primary care, and even primary care, you talk about the types of patients that initially walk in to a primary care practice. As somebody once said, boy, it could be one of 10,000 things. You really have to know your stuff and be good at it. And I think, most doctors really work hard at that. So maybe there's less of a difference between it, but I know if I were needing some specialty care, I'd want to know that it was one of the specialists at one of these centers.
And that always depends on whether there's continuity of care from the primary care provider's point of view, and whether he or she works with a network of preferred specialists that have had some kind of cohesive referral arrangements over the years.
And of course, whether or not your insurance actually covers that specialist.
Can this be and will it be the golden age for population health beyond the rhetorical kind of sound bites?
I think we're making some progress. I really do. I think there are some things and some innovation going on that is going to showcase some better health improvements and cost improvements from some players. I think a number of others are still early in this, and trying to build a population health program is not easy. And I think what happens is perhaps a lot of groups go at this and say, we're going to pull together telehealth and we're going to do this new cool stuff and that cool stuff. And at the end of the day, success in almost everything is based on first setting a firm foundation of basic blocking and tackling. And that basic blocking and tackling is, that one-to-one interaction with the patient. Did you stratify them correctly? Are you providing basic services, and are you relating with them so that they can then make the changes that you're trying to get done? And just saying, I'm going to pop a telehealth system in, or I'm going to take this new app and we're going to go manage people with diabetes, sometimes is a step beyond the first step of just building something that basically works.
Okay, one last question that I'm going to ask you about what you're most excited about in terms of looking forward into 2022. Perhaps what lessons we may have learned in the last 2 years that we can kind of pull forward into what's on the come, if you will. So, other than the golden age of population health, will we witness the ascendance of the importance of public health? Will that continue, and will there be adequate infrastructure investment to make the public health world as similarly, or with parity, if you will, of the acute healthcare system career path?
Well, I'm going to become the questioner. And I'm going to turn that question around to the expert in public health that's on this show. Give me your answer to that one, Greg. I mean, you've been at that for 30 plus years, public health expertise.
Yeah, I would watch what, thanks to Michael Lewis's book and based upon what Charity Dean was doing, the former health officer in Santa Clara County, if I'm not mistaken. She formed a company with the help of Venrock and Bob Kocher et al. Called the Public Health Company. And they're kind of I guess they're out there on the front end, maybe like back in the day, like today, who's top of mind in the Medicare Advantage space, who's top of mind in the ACO world. People or names will come up to you. You don't hear much about that from a public health perspective, but clearly the government is putting investment in upgrading public health. But, there's a long way to go. I mean, these are underfunded public health departments. There's no standard footprint necessarily. It's delegated from state to county to wherever. And I mean, it's just a hodgepodge thing. I don't have any confidence that there's going to be coherent leadership to really steward that along the path. But I think more people are talking about it.
And I would just add to that, this whole issue of the questioning of, whether you call it the questioning of authority, the questioning of the science, the questioning of whatever, that has permeated and really exposed itself during the COVID pandemic. I think that loud voice will negatively impact the potential funding for public health. It will be viewed as, instead of as something that is really important for society and helps us move forward, as something that is looked at like a government mandate type approach. And that's my fear. Clearly, public health is deserving of, and as a country, we should be funding this thing up. We've shown the weaknesses of it glaringly in this pandemic, but also because of some, by default, the public health groups themselves, messaging or what appeared to be changes of position, when in reality we knew more today than we knew yesterday. It's why things change. And I think some of the messaging was probably too strong, as if this works all the time, or it's 100% or 95% effective, and it's incredible, to, we believe this is good, but there's probably going to be something next. May have been better, although nobody likes uncertainty.
Yeah. The thing that causes me the most grief is, what's the public health business model? I mean, yeah. So I often joked with our friend and colleague, David Nash, that how will we know when we get there? And there being population health. And I always joked, I said, well, when schools of medicine and schools of public health merge into colleges of population health, then that's probably a pretty good indicator that we've made the transition. But I'm not holding my breath on that. And I'll just add one other thing. I've said, why not have dual reporting between health system CEOs and your local health officer? I mean, have at least a dotted line relationship. So, they have complex CEOs of health systems have tough jobs, a lot of constituencies, highly complex enterprises to manage. Who wants a dotted line reporting relationship to some county or government goon? I mean, no thanks, but these are kind of weird thoughts. All right, Fred, let's pivot. Let's talk about 2022. I mean, if you did a word cloud of quote innovation in healthcare, you get blockchain, AI, consumer directed health. What's exciting you as to where you think we might see some real innovation?
The thing that excites me the most right now is just the unbelievable final recognition of the impact of health disparities and this whole health equity issue. I think the burner's been turned up high enough that maybe it's going to create some boiling water, and we're going to actually, instead of paying lip service to these things, address it. Obviously, we just did the show with Dr. Joseph Webb, and he talked about some of the innovative things they're doing at their hospital. And that excites me, from Medicaid work, et cetera. I just think there's golden opportunities to fix these systems, improve people's health, and it's going to require us honestly looking at what are the fundamental causes of these disparities and addressing those. And some of those can't be addressed by the healthcare system, but the funds for them probably need to come out of the healthcare system because ultimately they'll impact the costs on the healthcare side. So, the healthcare system shouldn't be directing where to put parks and sidewalks and things like that, but perhaps by having some role in funding that, they can see some benefit in a alternative payment model coming back to them through savings in healthcare.
Yeah, the question is who's going to lead. And for those not familiar with Dr. Joseph Webb, he's the CEO of Nashville General Hospital, that is the primary academic medical center for the historic Meharry Medical College. So yeah, he had some interesting insights, and they're based obviously in Nashville. And Nashville is quite a for-profit proprietary health system culture. So it's interesting to hear what he's done there.
But at some point, we're ultimately going to get to this N of one that we know exactly what this person needs to improve their health. And some of that advancement may come through AI and become an ultimate sort of segmentation or assessment tool. But once again, you got to do the basic stuff first. And if these individuals, for example, so let's say you can take AI and you can suddenly better segment your population in rural Mississippi. Do you have anything to impact that? Do you have connections there? Do they have Wi-Fi? All of those questions that we've discussed on and on over the years with the show. And that's the basic blocking and tackling that I think we need to make sure we put in place first.
Yeah, and again, really the context for all this is in the face of a 9.7% increase in spending in 2022 to $4.1 trillion. So on this population health side of things, Fred, it seems like every health plan, health system these days has a vice president for population health management. What would you say to someone newly placed in that role or perhaps reassessing their strategy? What would you say is the top of mind considerations they ought to be thinking about?
Yeah, I think if you're out there looking at this saying, what do I do? Where do I start? The easiest way to do this, and first let me start with something that Esther Dyson said to us years ago, in that, don't do pilots. Pilots are like crack. Go ahead and do something that you can scale. That if it works, you can scale it up, because oftentimes you set up a pilot and then you try to make it big and it doesn't work. And so I would look at that, and I'd also say start simply. And this is just from experience. When I built the model to do disease management programs that we did with a community-based model and staff and the IT system, et cetera, We started with one disease state, but once the model was right, we could plug in any disease we wanted. And so if you build it that way and just say, wow, I started with diabetes and here's what we got going, and now I'm going to transfer that to asthma and bring in the clinical expertise to manage that in a similar way. And obviously you'll have some variation because some conditions are much more severe, occur more quickly, and things like that, and you may need to staff differently or assess differently. But if you have a basic model on how you're going to interact with your patients, with your providers, with the payer potentially, and build that, then you can say, okay, now let's ramp it out.
And what would be a typical front-end investment of time to maybe gather these facts before coming up with essentially a preliminary game plan?
Wow, that's a great question. And I guess a lot of that would depend on who's doing it. How much knowledge do they have in the first place? Because it really is a team. It's a broad group if you're looking at population health, from the clinical people to the behavior folks to the technology folks, the analytics folks. And you need to really bring that all together to solve that problem. It's not just a one person build this sucker. It takes a pretty substantial group.
And I assume there's a role for brokers, consultants, and benefits managers here in the narrative. What would that look like?
Make sure if you're offering something, it actually works.
Tell me more.
Some brokers are obviously really good, just like anything else. And and there are a lot of services out there that claim to make a difference. But when you look behind the curtain, and you and I have both done stuff with the Validation Institute, when you look behind the curtain, the outcomes may not be there. The measurements may be funny. But marketing is always good. and you've got to get beyond that. So I think brokers could play a huge role in this, because if they then go to groups like the Validation Institute or learn how to look at data like they teach them to do it, then they can be better for their clients and choose or recommend services that actually make a difference.
Well, I think the key driver here is the payment model. And into an all-inclusive capitation or, some kind of alternative payment model, I don't see a whole lot of progress being made. And I've been at this since 1984, when we were sort of introducing IPA model HMOs into Southern California back then. I hear a lot of talk. I really want to see the promise of digital health. I really want to see the promise of virtual care. And as Doug Goldstein talked about the other day, real-time care, tech-enabled but nested inside health plans, health systems, and provider groups. I'm skeptical. I would love to see it. I just don't see I think the ultimate metric is, does it deliver on the triple aim? And I see a lot of that in ad copy, but like you say, it's really the double aim. But as far as the aggregate savings on a per capita basis, I just don't see that happen. I don't know. I hope to be wrong.
I think I'm in the seat right next to you on this one, Greg, unfortunately. And right. A great way to finish up and then look to 2022, whatever may show up in the future.
Well, I've had a lot of fun working with you on producing these broadcasts and co-hosting with you. And, I think we have an impressive track record of some pretty top talent who have shared very candid views about what's going on in their world and how they see it working better. But we're part of the conversation, Fred.
Absolutely. And looking forward to working with you some more next year. And we'll see some great folks that we bring in as guests again.
There you have it.